all optimism and positive. But I also am a chairman of a department. I've been a associate vice chancellor, so I'm very realistic about budgets. So my energy there was just, we're really going to have partnerships to pull off the ambitious project to be like. Now, and when I talked to Russell, he says, don't worry, I have friends in Dutchland. They're going to commit lots of money. So I said, okay, no problem. Then why did I even have to say anything? Because Russell has many good friends all over the world, and they're going to match funds. So now I don't even worry about that. Oh, and then the last issue, I got criticized for being too positive about qualitative research because it's expensive and it costs money. But honestly, I don't know how. Bring in some person who really knows this area who can do it inexpensive. And I'm also reaching out to the foundation. How do you get a little bit of extra money so you can, because otherwise we're missing something really important, which will be the story. And open dialogue is about stories. And we'll get lost in quantitative data. And that was my intention on why it's important to have the qualitative part. It's just invaluable. And I've seen too many research projects where they get focused and miss telling the story, and in that story will be a lot of richness. So if I was too American strong, sorry. So I just wasted 2 minutes and 10 seconds catching up. All right. So I don't need to introduce you all to that, but in some ways when you think about fidelity, it has to start with the beginning. A next question is, why create Fidelity? So when Jaco and I first started with Mary, Jaco was like, look, we have to do the training. We haven't had Fidelity. We got away with it so far. And I said, but the model is you have to go to Finland and learn everything. And in the American research, if you don't have Fidelity being assessed, you will never be funded. So you could choose not to be funded. You could choose not to have clinical services ever get paid for, or you could use the tools you need. Well, so that was one. Oh, this is on its own going. Whoa, sorry. So why create Fidelity? One, it helps with training. Mary plugged that. She was an awesome trainer before, and then she said, oh my God, this is really helping to structure it in the beginning, and of course it's not the end. And I just loved your paragraph that you were saying about holding things. I was like, oh wow, how do we put that into the next version? Oh, it's moving on 15 seconds. I don't know how we did that. So help of supervising and monitoring. We do that with Emory. Every week we check in. They do their own peer checking in on this. It really makes better practice. Mary again reinforced that. It's expected in any behavioral therapy research or anything in dissemination and implementation. We got it in the SAMHSA National Registry in America as a best practice because it had the tool. It wouldn't have been in otherwise. Insurance companies, federal, at least in the US, expect it. We have two problems. We don't include how to assess in a Fidelity way good clinical practice. Mary talked about, and Jaco talked about in their training, a lot of it's just reinforcing good clinical practice, which is not necessarily even related to open dialogue specifically. Of course, open dialogue is trying to do good clinical practice. Here's where it might vary by the country or discipline. What is your expectation? But all of us know developing a therapeutic relationship, one with respect, dignity, good listening is, on any behavioral therapy study, that's what drives good outcomes, making a good connection. The other issue that's important in open dialogue research is that we say it's need adaptive. That means you can include a lot of things, but we don't put in our reports what are the other things they get. So in other research, we can learn from how they brought that into the assessments that go beyond Fidelity. Odessi, gold standard. We're going to learn a lot from it. We're going to be fully aligned with their assessments. we're going to do a good job. Treatment fidelity is something that that group is advancing, like my slides. So what extent do the core components of interventions of the system support it, effectively deliver care as intended by the service policies and procedures? So that was what drove their interest. Well, in the American system, the University of Pennsylvania developed the Treatment Services Review, which was a way of formally assessing other things you got other than whatever the intervention was. So did you go to AA meetings? Did you go to hearing voices? Did you also get couples counseling or other things? But how do we track that? In America, they developed ASAM patient placement criteria for patients for addiction. That evolved for co-occurring disorders to have a way of labeling organizations as dual diagnosis capable, dual diagnosis enhanced, or standard. And states like Pennsylvania gave you different money if you were better prepared to handle people with mental illness and addiction. So that might be potentially an outcome of open dialogue organizational stuff. They referenced it being based on the 10 steps that Jaco, Mary, and I created in 2015. So this information is informed also by other sources. These were the 10 organizational criteria that we developed in 2015, very similar to what you've heard earlier, that there was some network-centered care, welcoming environment, skillful communication, that they actually did the 12 key elements, shared decision-making process, things that you could see within an organization. The beginning of creating these key elements was a lot of listening to what was going on in the practice, asking very experienced therapists in Finland, hey, what do you do in meetings? And us listening to them and then reflecting back, oh, we saw that, but we didn't see this. And these were some of, again, the language they used, which we then evolved to more specificity into these key elements that are now translated in 15 languages. And my colleague from Czechoslovakia said, okay, in 4 months, I'll have a Czechoslovakian translation. Oh, you already did it? Oh. All right, we're going to get it up on the website. Thank you. Anybody else from any other countries? We don't have Greece. Someone from Greece? Yes. We need the Greece version. So 2 of them are structural. You know, are 2 people in the room or more? Is the family involved or more? Others are, maybe everybody should be using open-ended questions. Others are maybe a little more refined and specific to open dialogue training. But these are in those key elements. At UCSD, I'm following the work in the last 2 years, what I did at UMass, and we actually have a laboratory now working on fidelity. One of my colleagues in the laboratory just has a $6 million grant from PCORI, Patient-Centered Outcome Research Institute, to look at the fidelity of patient-doctor relations. I'm sorry for using that language, but that's what the money's on. And this includes creating artificial intelligence and some digital health support for the physicians to have better dialogue with their patients. We're figuring out how do we include that in families also. Okay. So one thing that this study will have to consider is how do we train raters? What kind of rating will we be doing? How often will we be doing tapes? But I could tell you from myself, learning therapy, listening to tapes was a really important component to how I would learn. And hearing it, and also if you're the supervisor, if you see a tape, it's way different than somebody telling you what they did. It's a very different experience. So we have a whole process for training raters, getting them up to snuff so they would be similar to others who have been doing it for a while. So we have a manual now that gets into a more detail of how you actually do the rating, which is different than what are the key elements. You know, the key elements are itself a gold standard clinically. The process, though, with which you listen to a tape is important. And one of the instruments we developed was this one. And this came from the research assistants who had to listen, postdocs, psychologists. So they're saying, I'm trying to listen to the tape. What was the utterance? Was it monologic or dialogic? And where did it fit in with the others? Sometimes we heard patronizing, disrespectful utterances. Well, that's, again, not a good thing. You got the red box. You don't want to have that. And sometimes there were significant silences. And in America, if we're quiet for 3 seconds, that's pretty long. And so we would also track every utterance. So the steps in a recording are permission of participants, coding the utterances, even using timestamps. Again, how elaborate one does, we could say we're not going to do it that elaborate. Or we could do it that elaborate. One of the fundamental questions we had was, what's an utterance? We're listening to patient utterances, but what's a clinician utterance? What if a clinician has an utterance of 3 different kinds of dialogic, monologic statement in their 2-minute sentence? What do you count it as? So each one of the areas we would rate as not good enough, acceptable, a reasonably trained person, and what would Jaco and Mary do? Excellent. So then, overall, how many dialogic statements were made versus monologic? Did they hit at least 8 out of the 10 fidelity items? Were there fewer than 2 patronizing or negative comments? So you could see that those were all factors. Here was an interesting, from our survey, this was the 35 people who say, we do open dialogue. They're probably like the people that we're going to engage in this study. We asked them, how many times were clinicians working as a team in their meetings? 40% always, 50% often, that means 90% most of the time. There were still 10% that were doing open dialogue, they thought, without a partner. Having the family network involved. And this is actually something interesting. I saw this in Finland, and I saw it in other places. Having patients and family support network there, 35% always, 40% often. That means 25% was less than often. So that still is a skill of how to engage people in the process. This one surprised me also on reflections, where I would think of it almost like a cardinal sign of open dialogue. 60% always, 25% often, and 15% not having it in their session routinely. Now remember, this is self-report, so they might be even overestimating their numbers. And the last one, tolerating uncertainty, particularly around diagnosis or treatment, 40% always did it, 40% often did it. So again, this is people's self-report. They weren't listening to their own tapes, but what they said about how they did these key components. So what would be acceptable from a fidelity point of view? So another part of fidelity assessment is assessing whatever change management process you do. If we pick organizations that are fully loaded, they're fully doing open dialogue, there'll be less of this, but we'll still want to be able to look at what are they doing in their charts? How's it being documented? How do family visits get documented? Because we might actually develop a best practice that we don't have right now. What's the best way to document open dialogue meetings? Do we have a gold standard? At the staff level, somebody else brought it up earlier, attitudes, skills, and knowledge. How much training is needed has been a big debate of this meeting. Also, I think we as a group haven't paid enough attention to the environment. Think of yourself as a patient or as a family member with a patient. Sometimes you go to the hospital, it's very inviting and engaging, and that you feel connected, and other times you don't. Wouldn't it be more open dialogue-ish if people felt welcomed coming in, if family members came welcomed coming in? But again, nobody's developed those fidelity measures. Those are just something interesting to think about as you create a change management process. So I'm finished with my presentation, but happy to have any dialogue, conversation about fidelity items.